Welcome everyone as everyone's connecting in and logging on. I think while everybody is doing that, I think maybe we'll kick off. We're a few minutes after 1:30. So just to introduce myself, my name is Stephanie Best. I am Associate Professor of Implementation Science, now based down at Peter Mac in Melbourne. And looking forward to chairing this session today. I have got some slides, and if I can share my screen and share the correct screen. Hopefully you can see that now. Lovely. Okay, so yeah, so we're very much looking forward to hearing Angela talk today. But before we get into that, I just would like to do an acknowledgement of country. And I'd like to acknowledge the traditional custodians of the land wherever you happen to be. For me, it's the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past and present. Let me stop sharing my screen at that point. So huge pleasure today to introduce Angela. Angela and I have never actually met in person, even though we both live in Melbourne. That's kind of like one of those things, isn't it? People say to you, you know, you both live in Melbourne, you must know such and such a person, you know, sort of when you're living in the UK, people do that to you, kind of going, well, it's a bit bigger than that. But anyway, Angela's going to talk with us today. The title of her talk is Using the CIFR Lens to Explore How Pragmatic and Complex Healthcare Improvement and Implementation Science Can Be Integrated. And Angela's got a really interesting background. She's got extensive experience of knowledge translation, and she facilitated the utilisation of evidence to inform decision-making at one of Victoria's largest health services. Her PhD involved an examination of the processes that are required in implementing improvements in healthcare, using evidence from research to drive change and influence design, delivery and evaluation of services, so that whole stretch across the whole process. And before coming into the world of implementation science, Angela developed evidence-based cancer guidelines with NICE back in the UK, so the National Institute for Health and Clinical Excellence. She's also got a myriad of public health sort of research experience, previously working at the Cochrane Consumer and Communication Review Group, and with Indigenous populations with work at the Menzies School for Health Research up in Darwin. Angela now works at the Health and Social Care Unit at Monash University and is working as an implementation practitioner, very much collaborating with industry partners. And so here she brings together implementation science guidance and support to enhance the research that the industry partners want to be doing, and really to aim, the ultimate aim, of course, as ever, is to be improving outcomes for patients and for clients. And so on that note, I'm going to hand over to you, Angela. Welcome.
Welcome. Thank you very much, Stephanie. I appreciate that introduction. Very nice. All right, give me 2 seconds and I'll start the screen share. And just a minor adjustment so that I can see everybody over here. Okie dokes. So while my title of my presentation reflects the use of CIFR to explore healthcare improvement and implementation integration, I also like to think about it as at the front line with CIFR. So what I'm doing here is giving us an insight into the practice, the actual on-the-ground work, that improvement and implementation work that's done in healthcare and in a hospital, and I'll go into some detail there. I too would wish to acknowledge the land on which I meet, and I too am meeting on the lands of the Wurundjeri people of the Kulin Nation. Not quite Naarm, which is Melbourne, a little bit further away though. That's why I don't know you, Steph, or haven't run into you. So our research aimed to explore how we bring together pragmatic and complex healthcare improvement with implementation science. How do they work together? Well, what does this look like? We examined an implementation process that was delivering a complex healthcare improvement intervention as a case study. And we studied the implementation of a routine mental health screening tool into a service providing antenatal care for refugee women. And essentially this provided the case study that we investigated. Oh, excuse me, I'm just going to move my script over here. So before I launch into explaining what we did, I wanted to just give you some background about the research setting that I was working within. So I was connected to a larger ARC grant and project that was looking into healthcare improvement, but across a system. And so as the usual practice with big ARC grants, there are several partners. And in this case, there were 4 health service partners and 1 state government department. The focus for me was one of these health services. So my PhD was focused on the work going on in, let's call it Health Service P. And we looked at one particular case study, which was about healthcare improvement. And we also focused on the implementation team and the work that they progressed to achieve the health improvement work. The research approach that we took was essentially an understandoscope that was embedded in the field. And in research talk, this is what we call an ethnographic approach. And just to remind us, it's the study of human culture. We're trying to gain an insight of an issue in its natural real life context as it progresses. It provides lots of thick descriptions about what's going on and people involved, and it enables us to study complex social phenomena, and particularly in my case, that of healthcare improvement. Now, as I just pointed out in my previous slide, I focused on Health Service P, so one of the service partners. It just so happened that I also worked at Health Service P. So I was able to bring a researcher in residence approach, really embedded, really walking the talk with the people that I was researching. Sometimes talking with them every day, sometimes observing weekly meetings and understanding their context. We used a purposely selected case study approach. And here's just an outline of the selection process that we used in order to articulate and identify why we chose this particular case study. We wanted to find a study or, an improvement project that used some co-design approaches. They connected and collaborated with patients. They used, or the context of their work was within a multidisciplinary model of care. And it was a project that was either undergoing or planning to be implemented across the organisation. So just a reminder that the focus of my research was the team who were delivering a healthcare improvement project. So ethnographic approaches tend to use qualitative data collection, in-depth interviews with implementation team. There was a lot of incidental conversations and dialogue about what was going on, how did this impact the project. And there were multiple rounds of discussion and reflection. I attended as many meetings that they hosted and that they would allow me to attend. And I also was able to collect documentary evidence. The interview guides, and indeed all of my thinking, was based around the CIFR 1.0. And so there are many different elements and concepts and constructs that were included in the data collection. I won't go into it now, but I also used a theory from business management called institutional entrepreneurship. That's for another talk. But there are elements that are very similar in what CIFR offers. There are just emphasis on different aspects of the work. So let's just dive into what this case study looked like. I'm going to use the CIFR 1.0, or indeed this is what CIFR is now as well, concepts to explain the particular case study that I involved. So in terms of the outer setting, and I know Matthew Chinman last time talked about the sometimes ambiguity between what's outer and inner. I'm going to work with this particular definition in terms of the outer setting was dominated by a national guideline that had been produced. It outlined what is best practice for antenatal care. There was external funding, but also internal in-kind contributions and commitments. And there was also a commercially developed screening tool that we wanted to implement. In terms of the inner context, the project was triggered by an evidence practice gap. So the screening wasn't happening at this antenatal care service. There was an urgent need, so I indicated that, and I'll go into it a bit more, that it was based, they were doing this improvement project with women from a refugee status, so there's pervasive patient need, as I said, delivered in a perinatal clinical setting with a vulnerable population. It was quite bottom up and co-designed, and so that means both the managers, the clinical managers, service managers and directors were identifying a need for this particular population, and indeed the academics that were working alongside them that also had roles as midwives were also identifying a need, and I refer to this now as a bottom-up approach. The antenatal setting, which will be basically the maternity services of Service P, also had departmental support for the work being undertaken. So, in terms of the intervention characteristics, I'm going to couch this around the aim of the case study. So it wanted to integrate routine mental health screening for antenatal care and link outcomes of the screening tool to referral pathways for further community support and care. The implementation, they implemented a complex multidimensional perinatal mental health status assessment tool, which is online, and they had translated it to the languages of the women involved who were attending the clinic. In terms of the individuals involved, please remember I'm talking and using CIFR 1.0, so the details around the changes to individuals don't necessarily reflect in this presentation. The project was delivered to quite a tightly defined population, as I indicated, vulnerable patient group, highly complex, just hiding through, and the clinical managers and frontline clinicians were also involved because they were going to be the people who were going to deliver the perinatal screening test which is a new practice. In terms of the process of this particular case study, they did quite a lot of implementation planning. They did a lot of assessments of barriers and enablers, and indeed, when they were planning their implementation, they looked for aspects of sustainability and scale up in their design from the get-go. They then went on to implement the screening tool. They used intensive education and coaching delivered by a midwife and or child health specialist, maternal child health specialist, to the midwives who attended these women. And then they refocused their sustainability design to see how that was progressing. Throughout the planning and implementation, they had an evaluation planned, and they delivered this with the intention of scale up across other settings in the service that we worked with, which had multiple maternity units in different geographical settings. So now back to my research. That's a bit about the case study that I was studying. Now back to my research. And so just using their process model, I just wanted to show you that my research focused in around this implementation of theirs. And it was some years ago now that I was doing this research. So apologies if I'm rusty on some aspects of that detail. In terms of data collection, we see here the number of interviews I collected or undertook, the number of meetings I attended, and the documents that I reviewed. When it comes to the analysis aspect of my research, we undertook a two-phase approach. One, we did a thematic analysis using a somewhat inductive approach, but influenced greatly by CIFR's concepts and constructs, and to identify what were the emerging themes coming through. In the phase two of the analysis, I then examined these themes against the lens of CIFR, and I mapped them, and I created what I call an analytic matrix to contrast and compare what our themes look like in terms of the CIFR constructs and domains. The intention was to gain an in-depth understanding of what CIFR looked like in this real-world context. And the intention was to, by integrating these two, learning this from our themes and constructing it against the CIFR constructs, we wanted to see if we could build some knowledge around how we could action what we've learned for other research projects or other improvement work. Again, so to the results, dipping back into the case study, and what did they achieve? Their intention was to implement it. So they were able to demonstrate that the screening tool and the process by which they implemented it was acceptable and feasible by the health professionals. So this is the antenatal nurses, maternal child health nurses and midwives. They were able to demonstrate screening rates while I was involved with their work. And they also looked at the perspective of the patients involved, and also here were able to demonstrate that the women involved found this acceptable and feasible. Just a note here, there were published papers. I'm not including them here for the benefit of confidentiality. So in terms of my thematic analysis, we were able to identify and distill what we were finding into three main themes: leadership, process, and context. This is what I was able to observe in the work and from the feedback that people were providing through interviews. So in terms of leadership, we saw concepts of agency, the capability for engagement, and the teamwork and collaborative approaches emerging. Agency is the capacity to act with purpose, power, and courage to initiate improvement and to respond to gaps or suboptimal quality of care. This was a really important driving lever for the people involved in the implementation team. They recognised how relevant and important aligning internal organisational strategic directions were against important external levers, such as the national guideline that was produced. They used this lever when they wanted to disseminate or engage stakeholders, so the midwives. And they brought expertise to improvement to their work as well. They galvanised using these two levers, the guidelines, the gap in practice, and the need from the women involved. This was used to galvanise belief in the work that was needed, and the desire to improve care was certainly something reported back by the midwives to the implementation team, who often referred to how their stakeholder group responded. The team identified, engaged others with also additional expertise. So sometimes they would bring in others to promote the message and indeed to explain further either the tool that they were was being implemented, and all of this was able to bring in and reinforce the shared vision. The team revealed quite a lot of passion and competence, and the team, which I didn't go into in the slides here, was made up of research academic clinicians alongside nurse unit managers and directors of nursing or midwifery and psychologists as well. So their passion was really strongly observed in the work that I did with them. In terms of engagement, I'm just spending a bit of time because this aspect of the work really stood out, was a really strong component to what I identified. In the implementation team, we saw strong diplomacy skills, high levels of communication skills, very emotionally aware, capable of reading the room, understanding the context for the midwives who were expected to take up a new practice and deliver the intervention, which was the screening tool. They were acutely aware of that context. They understood the time limits on the midwives and the interaction that the midwives would have with the patients, or I beg your pardon, the women involved in the antenatal service. They were constantly working to engage with the context, the IT involved, and the midwives taking up the new screening tool. So it's quite iterative and collaborative, which then moves us into the process theme. We saw, and I explained earlier, that they were very thoughtful in their planning and the execution of their implementation. They designed it so that it would be able to be scaled and sustained and scaled. They used a theory-driven approach. So they used a normalization tool or theory to understand how midwives might use and adapt their practice to taking up the new process of screening. And while they were very planned and thoughtful, they were very, very attuned to the iterative changes that might need to be done and the needs of the people involved. They had strong project management as well, keeping them on track and aware of actions that might be slipping, but particularly they were also very aware of the attention to people's needs or the stakeholders' needs. The context in which this happened was, as I indicated before, a bottom-up approach, on the ground support from multidisciplinary implementation team. There was a strong patient need focus driving the context, driving the will to change practice and use the tool. It was co-designed both with the midwives involved in delivering the screening tool and input from pregnant women as well. They had academic expertise through their academic clinical roles for some of the people in the implementation team. So the next phase of analysis was examining these themes and this work through the CIFR lens. And we aimed to bring further depth and understanding to the improvement process, but keeping in mind implementation science. And as I said before, we mapped our themes to the CIFR. And what we saw was strong alignment with what CIFR was talking about and included in its components. There were some limitations, and there were certainly some enhancements that I revealed through the research we did. So this is what this matrix looked like. I'm so sorry if it's giving you a headache at all the different cells involved. So along the left here are all our themes that I just talked about, and very clearly know the CIFR constructs across the top. So, as you can see, our leadership theme encompassed a lot of the CIFR constructs. Our process theme also spread right across the different constructs. So all of these elements were included in process. All of these elements were included in our leadership theme. In terms of our context, patient need and resources were a very important highlight to the context of our healthcare improvement work, and also in terms of designing for sustainability and scale up was I connected it to the reflecting and evaluating the concept of CIFR. Our context theme, unsurprisingly, worked and connected with the outer and inner setting of the CIFR. So just taking a moment to reflect on what the mapping revealed. It showed us an in-depth examination of CIFR in light of the real-world circumstance of undertaking improvement or implementing improvement. It provided depth and demonstration of the interconnectedness of the CIFR constructs. So they didn't necessarily operate in an individual component. They were all happening at once and to greater or lesser degrees. And it revealed this complex interplay of factors operating in the improvement work. All the elements of the complexity of implementation science played out in the real world implementation. And I found that CIFR enabled us to format these complex factors as well. So it was very useful. The other thing that I wanted to express was that the mapping process highlighted a really critical nature of the relationships between the constructs, so that process model and the way the implementation team functioned really gave depth and reality of how these how these constructs all relate with each other. So when I looked at the leadership component, I just wanted to point out that the multidisciplinary team demonstrated leadership through the agency, its skills that it brought, and the capability to engage with target clinicians. The key leadership capabilities included agency to lead, the capability to engage and communicate with the process and target clinicians, and the skills to facilitate the process continuously, learning iteratively throughout. So as I observed, there was continuous engagement, continuous fostering of what's going on, what can we do to make things easier, what do we need to address? And it pointed out that leadership is a complex and critical factor in implementation. It's relevant to context and process. And for me, it indicated the need for in-depth framing of leadership using this. So the work for me that needs to happen now is to understand from CIFR 2.0, what does this look like in terms, are we seeing this breadth of influence from leadership now captured in the roles subdomain? And I wish to acknowledge that these slides were taken from Matthew, who very clearly identified where things had changed and really moved around. So that was very helpful for me. And so it really identified, I need to go back and see, does this give us the depth that I was seeing in our leadership work theme? Interestingly, he indicated that there were 5 constructs taken out of this particular domain, and these are self-awareness and self-management and personal attributes, which I might need to reflect on further, but I think these were really important in the leaders that I observed. And indeed, researcher Elledge also identified that these are critical factors as well. So in terms of context, I'm going to focus in on the patient need. I would suggest that CIFR could go further to emphasise patient need in influencing the implementation process. It was a strong driver for both the implementation team, all of the individuals involved, as well as the target clinicians involved. They really saw this as an important critical factor and motivated them to change their practice. It was a key trigger for the improvement work, as I said, important to the implementation team and vital to the improvement work. And so I'm just going to reflect on Matthew's work here in terms of identifying the changes made to CIFR in the context space. And again, for me, more work to understand whether they capture the depth that I'm seeing here, particularly maybe in peer pressure. Two authors have looked at CIFR and say that this might need to be further developed and not enough details needed here. In fact, they want a whole different domain entered into CIFR. In terms of process, they are an identified limitation from CIFR 1.0 was aspects around sustainability. Again, major overhaul has occurred to the process domain in CIFR, so I need to understand how does this play out in this space. And in 1.0, there wasn't as clear explicit inclusion of sustainability, but again, I do acknowledge that the CIFR 2.0 could include it. And this is also something very important in terms of part of the implementation process. The implementation team sought to find ways to ensure sustainability with constant questions and understanding of the context to find out how to make this happen. And again, the author from before around the patient need, also reflecting that this needs to be highlighted. So interestingly, the constructs taken out of the process domain were these in terms of leaders, which is interesting because our leadership theme saw leaders connecting in with multiple domains across CIFR. So how that relates is something that requires further reflection. So to conclude, the research provides an in-depth understanding of how we integrate implementation science knowledge and how we might bring this to improvement work. We conclude that there's a vital role for leadership agency that can promote engagement and collaboration, continuously, iteratively learning with the end user in mind. We need capable leaders who are able to undertake and understand implementation expertise, capable of engaging that multidisciplinary approach to engage stakeholders. The importance of co-designing and understanding both clinician frontline need and patient need. But there is the opportunity now to look at CIFR 2.0 to understand how it captures these elements of real-world implementation or improvement. And that's the link to the paper that talks about this in depth. And as Stephanie indicated, I now work at the Health and Social Care Unit, so you can contact me there if you have questions. That's me.
Thank you very much, Angela. That was an absolutely fascinating and really nice and concise, considering the size of the study that you've obviously done and sort of bringing these sort of fields together. One of the things that I really enjoyed the way you were bringing in the CIFR 2 sort of, and reflecting on your findings that you found sort of previously. And it kind of just made me think, do you think sometimes we ask too much of some frameworks? Are we expecting them to cover too many things? Or do you think it is possible for us to look at CIFR 2 again and go, actually, we've thrown the baby out with the bathwater, and think about how some of those different factors should be feeding in?
Yeah. I asked that question of myself many times because particularly the consolidated framework. So it's a meta framework. It's wanting to incorporate many different elements to implementation factors. So I really like it from that perspective. And I valued how it helped us format things and understand all of this complexity going on. If only we could have a framework that captured this dynamic nature of the work. Maybe we just don't emphasize it and we just know it. Okay, I'll take that. What I'm trying to do is bring life to this framework and give it that depth. And it could very well be there. And indeed, that's what our aim is, to give it that depth and explanation. I'm currently in a role where practice is driving the implementation. And so I'm bringing to life what they're doing. And so in my current role and many projects I work on, what I want to see is there enough in these frameworks to give us that depth? So essentially taking the learning that I did in my PhD to the real world as well. So that practice-driven research is what I want to emphasize and bring to the fore. Yeah. But it really is a useful way of, constructing and framing things. We just take it that step further. I do, particularly when it comes to practice, because I'm seeing exactly what they're doing and I can give depth to that. And that's my intention now. So to give depth to implementation science and to highlight a lot of important things around relationships. I know you all know this is important, but it's just so nuanced. We need to explain that to people. Stephanie, you and I would get on really well. This would influence the way we talk about our project. And if you're in the clinical setting, you'd make time, you'd listen to what I'm trying to explain, what we need to look into and articulate. You might not, and you might even just do it intuitively. And so that's the detail that I really want our frameworks to bring to life. That's indeed what I want implementation science to explain and describe, that really nuanced. Sometimes it's very tacit, but it's really influential.
Absolutely, that whole sort of, I like the way you've had peer pressure, that whole sort of social influences. And I must apologise, sorry, I've dived straight in and asked you a question, Angela. Obviously, if there's anybody on the call, if you either want to put your hand up or you want to type a question into the chat, then please do. I'm sure Angela will be more than happy to answer any questions that you might have. I'll just pause for a second. Karen, let me bring you in at that point before I launch into more questions.
Sorry, I can't find my little hand, so I do apologize. I can put my physical one up. Thank you, Angela. This is really interesting. And I just wondered, did you find that the CIFR, the structure, was able to articulate or sort of describe challenging situations? So I'm just thinking about leadership. When we find if leadership is not performing to the level that we need to sort of implement change, that can be quite a challenging discussion. So I just wondered if you had sort of any tips or any sort of information on how you navigate, because people don't want to hear sometimes that leadership might not be, proving to be beneficial to the implementation.
Yeah, or indeed behaving to our expectations from them. I don't think in 1.0 it did as much as it could. Maybe if I look at the new arrangement of the leadership roles? I can't remember now. What's that new? Yeah, the individual's subdomain of roles.
Yeah.
Maybe it's in there, but you know, I also had another case study, and so what I'm going to be looking for is, did it capture the challenge when leaders were redeployed? Did it capture the challenge of, as you say, they're not meeting the expectations? So I mean, most of the time, this particular implementation team were very clear on their roles. Intuitively, they would pick up on things and be able to address it in either other meetings with other stakeholders, not necessarily within themselves. But in another case study where there was a problem in terms of role expectation and what was expected of one implementation team member didn't roll out. So when they went to actually deliver the implementation strategy, they had a massive challenge and massive pushback from the people involved. And when that implementation team member was asked, obviously offline, did you do any socializing, connection, explanation with this target group? And the answer was, oh, I didn't know I had to do that. So this role definition, so that's what the kind of detail I'll be looking for in this new subdomain. It's a really important question, Karen. Yeah, this is what I would be looking for.
Yeah, thank you.
My husband might kill me if I do a second PhD, but yeah.
Yeah, I think they will, yeah. Mila, I see your hand is up. Would you like to? I've just lost you now.
Oh, no.
Oh,
Hi.
just moved on my screen.
Oh, moved.
Hi, hi. Would you like to ask your question or comment? Make your comment.
Sure, it's probably a bit of both and quite a big one, so brace yourself, Angela. Thank you very much for your presentation. I've enjoyed it. My question kind of encompasses a little bit of everything you talked about. So about your current role, about the implementation science in healthcare setting, etc. I find that when it comes to implementing new either tools or programs in healthcare setting, it's always a top-down approach. Hence, it becomes really difficult to, first of all, explain to the leadership as to, you know, why this is important, because they come with preconceived conceptions of these are the outcomes we want and this has to happen. And then it's really difficult to then take in perceptions from patients or for the people tasked with implementing the change. That's probably a comment, but then the question in there is, how do you talked about using ethnography as a basic approach to evaluate, or as a framework to look at, you know, how this tool was implemented. And that is a very qualitative based approach in a space where everybody is quantitatively focused. So the question is, you know, how do you marry those two up and try to show the value of implementation strategies that go beyond, you know, let's do the education. You mentioned couple, and the one around the leadership spoke that is an implementation strategy itself, that we have established a leadership buy-in. So how do we, it's quite a big topic. You need to have the specialists who are implementation science focused, that understand at least the mixed methods approaches to doing change in organizations, and then get the leadership buy-in and get the understanding that the change is important, but we need to make sure that the context there and the preparation is there so that it can be, number one, implemented with fidelity and can be successful and sustained. So yeah, I'm just keen to hear your overall comments, and sorry for a long question.
No, that's absolutely fine. Thank you. It's so maybe talking from practice, because they didn't necessarily have an implementation specialist with this case study implementation team. They had some insights into implementation science, but certainly in my current practice, battle is a strong word. It's a dialogue that is ongoing with the groups that I work with. And so it's the way I might talk about and understand implementation and explain to project deliverers why these concepts are important to understand in a qualitative way, and indeed the way we might measure it in a quantitative way. We've started to use the program logic approach, so everyone knows what we are wanting to achieve, but indeed there's an implementation side of that program logic that we're also wanting to look into. And I haven't got a golden answer. We have this dialogue all the time and explain each of the concepts. And this is why implementation science is so important, because I can say we need to understand readiness. What are the things that are going to challenge us down the track? We need to understand this in terms of pilot work, and so we do a readiness assessment, or we consider how this would look. There's always an element of pragmatism that's going to come into what I do, because I'm a practice-based researcher, and so we need to juggle that as well. There's no clear answer. It depends on what we're doing, depends on the people I'm working with, and how many battles I want to have. So if I get this concept and we look at what's going on here, then I'll let them go on another area of measurement.
Thank you. Well, just interesting to hear, because you said that your role was based as a practitioner and that the organizations are coming to you. So obviously there is a bit of at least top understanding of what the value of implementation science is. And, you can demonstrate that for them it's connected to better patient outcomes and impact, which is what every organization wants. So it was, I'm Queensland based, so maybe we're a little bit behind New South Wales and Victoria in terms of that big picture of what implementation science is, but it's really nice to hear that it is making its way into being embedded in healthcare systems. So hopefully in my lifetime it comes to Queensland as well.
It will, especially if you're there.
Thank you.
Thank you. That was a really, really interesting question and discussion. Anybody else got any questions that they would like to ask? Please feel free to pop your hand up, or if you're more comfortable, please feel free to write something into the chat. While everybody's having a little think about questions they might like to ask, I wonder, Angela, can I just make a comment? I really liked your table that showed the themes that you'd identified from your data, and the CIFR constructs, the major ones across the top. I was really surprised with the leadership one, that there was nothing that fitted into the characteristics of individuals.
Yeah, I thought so too when I was reflecting on it as well. I think, I tended to maybe put it into the process side of things. I too. Maybe
I know what you mean. I know what you mean with CIFR one, because I sometimes struggled with where something sat.
Yes, of course, it's subjective. Yes.
And so,
and I totally accept that, and I would accept a relook as well. Maybe what I was trying to convey was that leaders it wasn't sort of this separate thing for me. They were doing all the time. They brought their outer knowledge. They were a very outward looking team. They were very well connected within the hospital and indeed outside. They constantly fostering and engaging people, talking about the project. So maybe that's what I was, let's say, distracted with the way they were going about it, and their qualities. Yeah, but it's a good point. I take.
Yeah, no, just interesting. Now, I wonder if I could ask you a methodological type question. I know that you analysed various documents. You did some interviews, and so there's two things. But you also said that one of the things you said very, very early on in the presentation, and this is, I think, it's the beauty of being an embedded researcher, is that you have those incidental conversations.
I didn't count them, sorry.
No. So what I was just interested to, I'm absolutely fine. what I was really interested to ask is how you go about capturing those incidental conversations. I've spent a lot of my last how many years being embedded in practice, and you're right. I think that you do get influenced, don't you, by those sort of conversations that you kind of hear. But how do you go about capturing those? If you're thinking about writing a paper and you want to be able to acknowledge the role that's had, and part of the importance of you being an embedded researcher.
It would be a quick chat before or after a meeting where the implementation team were meeting. It would be physically close to these people doing their work. So I would knock on the door, corridor conversations. I'm looking at, this particular thing. How did you do that? What happened there? And they go, oh, yeah, sorry, yeah, blah, 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 blah. So it was quite a casual approach. They were fully aware and introduced to me. I knew these people as well. But there were 2 case studies, so I knew both groups as well. They knew what I was doing from the get-go. That case study selection involved dialogue. I'm here to do this and understand that. And so they were very welcoming and open to, oh yeah, tell us what we're doing wrong. And I would obviously not do that, but they wanted the critique of the implementation practitioner with them. I didn't do that too much, to be honest with you. I did stay a little bit apart. Maybe if I was doing using an approach called developmental evaluation, where my role would be to feedback. So you're doing this, but have you asked the group yet? Or have you checked what the IT systems are? So I would do a lot of feedback to them and they would listen to me, whereas I played a observation role in their meetings and their work. So
are you very good at having those conversations and then filling in your research journal?
Yes, it was horrendous. I nearly put up the map that I gave my supervisor when I first went to her with the theme. So you saw 3, but it was 23 themes, So, but, that was actually the most exciting point in the PhD. And to be honest, my supervisor nearly fell off her chair. She's, oh my gosh, we got gold. So, and I felt the same too. I was quite elated. And I don't like compartmentalizing things, but I just needed a way of understanding, which is why CIFR is very useful. And as is the NAS framework, there's a lot of implementation of technology. We're starting to see some nuance there. And this is why practice-based implementation researchers or practitioners who do research just give such depth to the work. And that's really what we want to see. I want to see in implementation science. Yeah.
Applied in practice. Yeah. I know exactly what you mean about that, not wanting to compartmentalize, but at the same time, we do need to a certain extent, and ideally to be using the frameworks that are available to us so that we can then communicate with other people around. These are sort of some of the similar things. That's right. How we can meet people in conversations. Whereas if we don't compartmentalize anything and we leave it all ethereal and kind of like out there, there's no way of bringing people together. There's no way for us
undefined.
to progress our learning, is there? So
no, absolutely.
Yeah. Oh gosh, I've just seen time has totally got away from it. Karen, you've got 3 minutes tops.
Yeah. Thank you. Just on that discussion about sort of incidental conversations, and so we're doing some research with care coordinators who are in rural and regional areas, and that is one of the things that is they feel isolated because they haven't got, because they're not located. They're located in a sort of a small area. They don't have those conversations. But what they do have is we have embedded researchers who seem to work really well together and probably, supporting each other in the different roles. And that has sort of that dynamic has actually worked really well. But the thing is that the researchers will not be part of the team when hopefully the program is, scaled up, or, we have sustainability and get ongoing funding. So it's just, you talked about relationships, and that's a really interesting dynamic, I think, that is really important to sort of understand, and it really has come out quite strongly in our research.
I absolutely agree. Maybe there's an implementation strategy of that researcher contact, training or embedding the knowledge with an existing member of the clinical care team. It's really important. I mentioned this concept of institutional entrepreneurship. It's a business organisation theory, but what it tells us is where the point of change is happening, you need close people who understand, but people on the outside. Rock the boat with 1 foot in and 1 foot out of the boat. Have a team that crosses those boundaries. So what do we do for future teams? We either train someone to do the role, we instruct them, we ask them to take on these competencies, which METS is now really nicely articulating for us. But this is the nuance of implementation work.
I think this is the crux of it, isn't it? So there's a whole lot of the process stuff that we know absolutely is important, and identifying sort of strategies, and I have conversations with people about education and funding and all those kind of things. They're absolutely totally important, but it's all this underlying stuff, really interesting kind of that gives you that sort of real interest.
Well, I look forward to a paper, Karen. I'd love to read it.
Well, look, we're right on 1/2 so at that point I just want to say, Angela, thank you so much for sharing your experiences and bringing it right up to date with sort of the new CIFR version. It's been really interesting and really sort of sparked off some thoughts in my mind, so absolutely, I've no doubt it has with everybody else. Thank you very much, everybody else, for joining.
Thank you all. The privilege is all mine. Thank you very much.
Toodaloo, Angela, and look forward to seeing you all at the next ISIG.
Thanks.
Have a great afternoon. Toodaloo.